Well, good afternoon, everyone. My name is Tammy Geltmaker, and I'm the Program Director for QSource. On behalf of the Indiana Department of Health and QSource, I'd like to welcome you to the September 14th Public Health Update webinar. Our public health updates aim to educate, promote, and protect the health of people in our communities, where we live, where we work, and learn together. We can achieve this goal by trying to prevent illness and diseases, by increasing awareness and promoting healthy behaviors. We can also reach our goals by educating ourselves and others about emerging public health issues, detecting disease patterns, and social determinants of health risks. During today's session of our Public Health Update series, we'll be promoting September as Sepsis Awareness Month, and our speakers will also be discussing strategies to help prevent respiratory infections this winter season. Our agenda today includes opening remarks. We'll also have our featured presentations, and they will be followed by an opportunity for question and answer with our speakers, as well as some closing remarks. Before we begin, I want to run through just a few housekeeping items. We have your lines and your microphones muted at this time, but we will be opening both during today's webinar when the Q&A portion begins. In addition, we do have the question and chat feature. That chat box is located on the right side of your screen. And today, Mitzi Daffron will be monitoring the chat feature as we move through the presentation. So if you have a question or a comment, you can feel welcome to post it in the chat. We'll either respond to you either in chat or on the call. Now, we do encourage you to please monitor that chat function frequently for information, resources, and answers to questions. As you may know, QSource is the Quality Innovation Network Quality Improvement Organization, or QuinQIO, for Indiana. We convene, teach, and inform healthcare providers. We engage and empower patients and inspire the entire healthcare continuum by sharing knowledge and spreading best practices. Thank you for taking time to join us, and we do appreciate all that you do to improve quality and achieve better outcomes in health and healthcare at lower costs for the patients and communities we serve. As referenced earlier, today's Q&A session is one of many webinars that will be hosted by QSource. Each session will be made available for on-demand learning to share with your peers, and today's presentation will be made available as well. As you can see on the screen, we do have a couple of polling questions for you before we begin. First, we'd like to know, which setting do you work? The poll is now closed. It appears that 50% of attendees today note that they are from other settings. 25% are from community-based. 12% are from hospitals, and 12% are from long-term care. Thank you for answering that polling question. We do have another polling question for you. We'd also like to know, what is your role in your organization? All right, well, thank you. So it appears that 63% of the attendees note that they are from another setting. 9% are from long-term care, clinical administrator, 9% nurses, 9% quality improvement specialists, as well as 9% patient advocate. Once again, thank you for your participation in the polling questions. So it is now my pleasure to introduce today's speakers. Our first speaker is Dr. Rebecca Hancock. Dr. Hancock is a quality and patient safety advisor for the Indiana Hospital Association. Her clinical specialties include sepsis, healthcare quality, and geriatric clinical research. She is a clinical nurse specialist and certified clinical research nurse with a PhD in nursing science. Today, Dr. Hancock will be discussing sepsis awareness. Also joining us today are Pam Pantonis, Deputy Health Commissioner and State Epidemiologist Office of the State Health Commissioner, and Dr. Shirisha Vupalanchi, Medical Director, Office of the Chief Medical Officer. At this time, I'd like to turn it over to our speakers.
Thank you so much, Tammy. I guess I'm first. And I'm Rebecca Hancock, and I just want to thank you for inviting me here to talk about sepsis, to get our word out into the community and to school nurses, as I saw on the line here, as well as quality improvement specialists out in the outside the hospital setting, which is normally where we're doing our QI work through the Hospital Association. But we've worked with QSource for a long time, doing long-term care education for sepsis and actually traveling the state and having a good time together. Actually, it can be fun to do this kind of work and educate others. So today what I'm going to do is I'm going to talk a little bit about the resources that we can provide you that are available, as well as links to other resources, what actions you should be taking for sepsis, and some signs and symptoms to watch for. If you would please put the Q&A questions in the chat during my 30 minutes here, because I have to leave right at 2:30 to do another sepsis webinar. So I just want to start off with the future isn't written, it can be changed. And that's the theme of our Sepsis Awareness Month, is Back into the Future with Sepsis. Next slide, please. Back into the future with sepsis, we're going back to the basics, as well as looking at some future technologies that might want to incorporate and some future populations that might be best to look at for sepsis care as it's emerging in the clinical and publication environment. So we've got a series of webinars coming up and ongoing. Today we're going to talk, tomorrow we're going to talk, there every Thursday at 3 p.m. To discuss where we need to play catch up for the pandemic, as well as move forward in our care for patients to make sure we're using the best technology and best care processes. So back to the basics with sepsis pathophysiology and bundle compliance. Some of you don't know what the bundle is. I'll talk about that a little bit. Sepsis diagnostic, how can we get advances? How can we get to a diagnosis and a appropriate antibiotic as quickly as possible? Emerging information on maternal sepsis and quick treatment for that. How do we manage the fluids that we're giving patients in order to buy some time to get the antibiotics circulating and replace their fluids that they've lost? And also universal hygiene and sepsis prevention, which we've presented on before, but this is particularly in reference to sepsis, and Annette Handy and I'll be doing that. Next slide, please. So this is the list of the speakers that we've had, and if you need some recordings, let me know, but these are the links to sign up for any of these, and I'm very excited about the content. Some of this content I wanted to have for about 2 years, maybe since 2020 when I first heard about some of it, but we had other things on our mind in the meantime. So these are our registration for our webinar series. Next slide, please. When we talk about Indiana and how we're doing on sepsis mortality, and this is from the CDC, and it's taken a look at relative mortality rates across the nation from 2020, deaths per 100,000 based on death certificates. So as you can see there, we're in the second to the worst category in Indiana. And we know that we have a lot of comorbid conditions that often drive our poor outcomes in Indiana, but I don't think we can take that as an excuse. So what we need to do as healthcare clinicians is be voices about, could that be sepsis? Listen to people's signs and symptoms, and take a look at some of the risk factors that I'm going to share, and could it be sepsis? Could it be going from an infection to sepsis? And I'll mention right now that on our website, survivesepsis.com, Lindsay Weaver did an excellent video for us, I believe in 2019, and we keep it up front because it's her experiences as an ER physician talking to a patient about what will happen if your infection becomes sepsis as they're leaving her ER, and telling them what to watch for. So I encourage you to take a look at that. Dr. Weaver did a great job. We haven't changed it since then. Next slide, please. So when we think about sepsis, we as clinicians and out in the environment, what are the risk factors? What should we be thinking about that a patient may be getting a worsened infection such as sepsis? And recent UTIs, pneumonia, or other operative events, so that they have lines and drains in, or surgical sites? Do they have diabetes? Are they on steroids for immunosuppressive therapy or chemotherapy? Did they have an elective surgery? Because we think we come into the hospital and everything's hunky-dory. The truth of the matter is we're poking, we're prodding, we're opening new orifices on patients, and going into every orifice that you got. And that is an opportunity for infection. Every time, we know that, hospital-acquired infections, but also out in the community, cuts, and so on. Chronic renal failure, alcohol abuse, splenectomy, sickle cell disease. Those are the things that we can we know are comorbid conditions. There are a few other things that we can't change: patient's age, the older more likely to get sepsis, males more than females, and African American more than whites. So these are the things you think, might this infection be becoming sepsis because of these comorbid conditions? And we need to watch these patients a little more closely. And this is the adult population. Next slide, please. When we think about what sepsis comes from pre-existing infections. And we know that it varies across the age range of what is the most predominant source of sepsis. In the pediatric population, the adult population, respiratory or pneumonias are the most common. But then you get into UTIs with genitourinary, abdominal pains with severe, unrelenting abdominal pain. Patients describe it as excruciating pain. The caregiver might not experience it or know that it's that bad, but that's how the patient experiences it and describes it. Wound in soft tissue or skin penetration that can cause sepsis in the pediatric and all adults. So you need to do a full body assessment. What could be going on here? Was there a spider bite? Was there a scratch somewhere? When we get in the older adults, the most common type of infection is a urinary tract infection. So it reverses. It's UTIs and then respiratory, then abdominal, which is pretty common, and then skin or soft tissue last for older adults. But I want to look over at pediatrics for a minute and notice the device-related infections in peds is at 9.3%. It's very easy to identify that as a source. We call this, sepsis is called a trash can diagnosis because it has a lot of things going on within it. I don't think it's a trash can. I think it is, next slide, please. I'll show you what I think it is. Not a trash can. It's not something we can't figure it out. But part of the problem is that 22% of the sources of infection are unknown in sepsis. So you're kind of shooting in the dark, but you use your broad spectrum antibiotics, shooting in the dark. You may not know where it's coming from, but the blood culture may come back positive, and then you at least know what pathogen you're treating. I consider sepsis an umbrella term, and I liken this to my experience with Alzheimer's disease, where dementia is an umbrella term, and you have pugilistic, and you have Alzheimer's, and all these different types that are the cause, the actual type of organism or process that's going on that kind of dictates what the outcome the trajectory of the care will be. Sepsis is the same way with you've got all the different sources, and that kind of indicates what your trajectory will be and what you're trying to treat. But it's not a trash can diagnosis as has been thrown at it. I believe an umbrella term is more appropriate. Next slide, please. I also want to mention that there are 4 general types of sepsis, and that's parasitic, bacterial, viral, and fungal. And we were talking a little bit before the webinar about how do you take a look at Candida auris as a topic and where that falls in the treatment. But again, parasitic, bacterial, viral, and fungal. And I'm going to focus primarily on bacterial here and what we know about that because CMS and the world has done a great focus on bacterial sepsis. So the patient experiences on the right-hand side, they're shivering, extreme pain, pale discolored skin, sleepiness. I feel like I might die and shortness of breath. This is an example of one of the flyers that we have in our Sepsis 2022 toolkit that you can print off and put up somewhere just to keep patients aware. They also might have diarrhea, vomiting, and sore throat symptoms. That could be a common infection. But you got to keep an eye on it to see if it's emerging into some of the symptoms on the right. What the patient describes as symptoms are different in a way. They're additive to what we're looking at as clinical signs. Next slide, please. Try to put references on all these for you if you need to go find them. So in this case, there's a systemic inflammatory response syndrome that the patients experience. And here are the 4 symptoms for that. Fever above 100.4, heart rate above 90, respiratory rate above 20, and white cells above 12,000. The other thing that comes in really quickly with our older adults is altered mental status, or maybe even a fall may precede it because they get dehydrated and then their balance is off and they fall and you think, fall, mental status change, might they have a UTI? And then you go down the process of figuring that out. There are some other indicators down there under other that they may have delirium, anorexia, malaise, urinary incontinence, feet weakness, functional decline, withdrawal, and agitation. That's primarily in the older adults that we see a lot of that. But these atypical symptoms occur in the very old and very young, and that's why it's harder to diagnose in those areas, those age ranges. Less responsive in some cases, maybe not speaking in the children, but also older adults who may have some dementia. Anyway, these are the signs and symptoms. So if you have a suspected new or worsening infection, plus those 2, systemic inflammatory response syndrome, you have to have your warning sign has to go up internally with these things saying, could this infection be progressing to a sepsis case? Next slide, please. So again, I want to reiterate that what the patient's experiences with the sepsis on the left is a little different what happens on the right with what we're looking for. Significant edema, they're not going to be looking for that. They're going to be thinking about how they feel. But I want to mention a couple other things about patients is that if they're being treated with Tylenol, Advil, steroids, these antipyretics will mask that fever. So oftentimes older adults don't have fever anyway. So that's not always a sign and symptom to watch for. But also the other thing is with their heart rate, expecting their heart rate to get above 90. Some patients are on beta blockers, so you want to give it a second thought about that. Are they not having an increased heart rate? It looks like they're getting a worsened infection, but they're on beta blockers, so maybe that's blocking that increased heart rate. But other things to watch for are listed on the right, in addition to the Sears criteria that I mentioned. A lactate level and a WBC level above 12,000. I forgot to put that there, but the lactate level greater than 2 is what will be checked when they come into the ER. Over 4 is considered severe sepsis and septic shock area. But Sepsis Alliance has some good resources that are listed on the left for it's about time. We're trying to get them to think about sepsis on an equal plane with strokes and acute MIs. They are all three equally important emergencies. When you get to the ER for sepsis, you have certain metrics that are interventions that need to be done within 3 hours of diagnosis or time 0. So time matters equally with sepsis as it does with UTI, with acute MIs and strokes. Sorry. All right, next slide, please. One thing that we talk about is non-ventilator hospital-acquired pneumonias. For those of you who are involved in the hospital situation at all, you know that we've been working on ventilator-acquired pneumonias for a long, long time. But the truth of the matter is pneumonias occur whether you're on a ventilator or not. And we have not done a very good job of taking care of preventive resources in order to prevent pneumonias in the hospital. I mentioned all the things we do to patients. They're in an altered environment, eating foods in their room, not washing their hands so much. But this non-ventilator patients who get pneumonia who are not on a ventilator has a 15 to 31% death rate associated with it. But this study that was featured in the Wall Street Journal by Quinn and Baker said that if they give the patients a toothbrush and gargle with mouthwash within 20 minutes of going to the OR for an elective intubation for surgery, they're able to greatly reduce the number of non-ventilator hospital acquired, as well as giving the patients toothbrushes so that they can brush their teeth 2 to 4 times a day. ADA, American Dental Association, recommends 4 times, but at least morning and afternoon. Prefer after meals as well. So toothbrushing, oral hygiene is an incredible intervention that can be done everywhere. I preach it to my parents. I preach it to my kids. They don't want to hear it anymore. But the truth of the matter is we have not given oral hygiene justice in the way of infection prevention as we should in all of our care settings. Next slide, please. So all you're doing is just invest in a toothbrush and making a big difference in pneumonia prevention. So this is a picture of how bacteria progresses a cycle of bacterial growth in your mouth within hours, from 3 to 13 hours there. That's disgusting. What we want to do is do oral health. What is your patient care policy, and what are you doing to teach and remind people about oral health? I don't think when we go to the dentist, we really get the true story about what all we're preventing. It's gum disease, it's decay, but we're also working on sepsis prevention and infection prevention specifically. So let's all brush our teeth. Next slide, please. We as healthcare professionals are the spokespeople, and our word getting out to others through our telling of our family and telling of and reminding any patient that crosses our path about the importance of oral hygiene makes a big difference. But the more clinicians speak about it, the more the word can get out. And October is Dental Hygiene Month, by the way. So what's going to happen when they get to the hospital if they do have a positive sepsis diagnosis, that they're checked as soon as they get there? Their lactate level is going to be low. They're going to have a culture and sensitivity blood test drawn to see what grows. And then they're going to get a broad spectrum antibiotic if their lactate level is greater than 2, which indicates organ failure. And sepsis essentially is an infection that involves organ failure as defined by patient's signs and symptoms, as well as this lactate level. So there are things you're going to do. Give them fluids, significant amount of fluids, 30 mils per kilogram of body weight, if their blood pressure is low. So the big deal with that is fluids matter. Fluids help circulate your medicines. They keep your head intact so that you're not dizzy and confused, as can happen with cardiac meds for older adults. But in general, people can become dehydrated when they're not feeling well, and that in turn can affect the cognitive status, and that can cause the delirium that we see. And they're going to give them fluids when they get to ER. So my comment is, get your people drinking fluids all the time to prevent this delirium that occurs simply because of dehydration that may also coexist with your sepsis and infection onset. So there's a number of things we continue to do if the fluids don't work, but then we wait for 48 hours to see what the culture and sensitivity returns so that we go from the broad spectrum to the very specific antibiotic that will be used to treat their infection if we didn't get on the right track initially. So that's what happens when you get to the hospital, is the sepsis hospital bundle, and we all track what percentage of compliance we do with that in the hospitals. Next slide, please. It matters because the sooner you get there, the sooner you can get the bundle. So, but you have to have the thought process. What is sepsis and what am I watching for in our clinical care? I include this resource here of the Patient Education Zone tool. I know QSource this is originally from a QSource entity that is posted on Sepsis Alliance, the link's there, but this is no fevers, no chills, and a look at what's green zone and what's red zone. And I'm going to reference a patient education resource that we have on survivesepsis.com, which is our website, patient education, in a moment. And we have another zonal tool in that we've used for sepsis identification too. I see a question, is there an emphasis being placed on education of outpatient providers, primary care providers, to think of sepsis when patients call in the office with symptoms, thinking in perspective of insurance companies moving to prior auth for ED visits? Well, I think that is something that needs to be happening. I'm not sure it's being done as much as it needs to be, and it depends on who answers the phone as far as how they're able to prioritize what is a worsened infection. And that's a question. Have you had a recent infection, which means that it could be emerging into sepsis? There is an emphasis, and there are a lot of material out there for the outpatient providers. And some of our hospitals are choosing to do that on their own. So it's kind of like if the hospital provider is working, if the PCP is working with a hospital, they're getting that education often, but not enough at all. And I can't imagine the prior auth for ED visits can be a timely resource at all. So, but thanks for that question, Sarah. Hope I answered it for you. Let me know. So anyway, this is the resource for your patients, and your healthcare provider can give that to patients. Next slide, please. So we've done for the September Sepsis Awareness Month, which is an annual event that we honor that is international. There's also, and I mentioned this right here, there's not a resource for this, but it's sepsisalliance.org, the sepsis.org website. There's a sepsis summit coming up on the 28th and 29th of September that you can sign up. It's free and it's all virtual at sepsis.org. So this is what you can do to get better educated, sepsis.org, in addition to the webinars that I already mentioned. We do post our Sepsis 2022 toolkit at survivesepsis.com. And at that, we have a social media campaign. As you can see on the bottom right, you can print out, I am a sepsis champion, post it on your Facebook, LinkedIn, other social media pages as we're doing at IHA, or you can just follow us and share on your page. And that will give your Facebook entity, your LinkedIn entity, education about sepsis. You can also take the social media information that's out of the back of this sepsis toolkit and share it on your own through your own communication marketing departments. We have in there table tents with education on them, as well as signs that have QR codes on them for our English and Spanish version of our sepsis education. That is very comprehensive, but it goes into prevention as well as recovery and the role of the caregiver in that sepsis education. Yesterday was Sepsis Awareness Month. We had a government proclamation for that, and we posted that on our webpage. So you can also do that on your own, but yesterday was World Sepsis Day. Next slide, please. We need to have an awareness and a process for treating sepsis across the continuum. Awareness identification in the outpatient setting, what we do in the hospital, screening, bundle compliance. Thank you for bringing up primary care, sepsis recovery processes, and sepsis prevention. So there's a continuum approach to sepsis and infection prevention in general. Next slide, please. One thing we've looked at is what do we do for prevention? We partner with one another at different places across the continuum, and these are the parameters with which we can do sepsis prevention: hand hygiene, mobility, good nutrition, immunizations for pneumonia, COVID, flu vaccines, oral hygiene, address the post-sepsis symptoms, Patients with post-sepsis syndrome often have a number of symptoms that are highlighted in the sepsis education that I referenced. That may be sleep deprivation. They might not be sleeping well, not eating well, depression, anxiety, some PTSD from being in the ICU. Taking a look at that and getting treatment and care for that, as well as keeping patients well hydrated and medical follow-up within 1 to 3 days. And what education you give them is based upon the source of where that particular infection began, because you want to treat the source. Next slide, please. This is the sepsis education that I described. It is on the survivesepsis.com webpage. The QR codes are available here, but it's about a 6-page document. Again, very important that it gives what is the role of the caregiver as the eyes and ears for this patient. The picture on the bottom right are the signs and symptoms of post-acute sepsis syndrome that patients may have. And so they think they're dying. They think they're not ever going to be any better. But the truth of the matter is there's a logical progression for recovery with post-sepsis syndrome and post-sepsis signs and symptoms that do get better. We have a wonderful example of someone that Mitzi referred to me that I check in on every year. She thought she had no idea what was going on. She was 28 years old. And over the course of time, she got better finally. She realized she wasn't alone. She had another baby at age 28, her third, and then she went back to school. And I haven't talked to her in about a year, but she inspired me to provide this education I had her look at before we sent it out. But See It, Stop It, and Survive It is what we focus on as conceptual approach to sepsis care. Next slide, please. I did pull out for those on this particular call resources out of the toolkit that I thought would be most valuable for you. We do have access to what's called the Cynosure Learning and Discovery Connection, the Improvement Connection platform. And if you go on that platform, there's about a 1-hour module that is free for visitors to the platform on sepsis education, something you might want to try if you're going to be in the educational side of sepsis. Sepsis Alliance for Nurses, Sepsis 101 is a really good, easy 1-hour video of teaching nurses what to look for in sepsis at the beginning stages. Group discussion. We have a patient care narrative in there that we use during our traveling road shows with QSource about what happens in healthcare transitions. And this is an example of what happened from the hospital to post-acute care, where a patient ended up dying of sepsis and some of the gaps that we identified. And there's a podcast that goes with it, and then there's a narrative and pre and post discussion questions that you can do as a group activity. I mentioned Dr. Weaver's podcast that we have listed on the webpage. There's also Sepsis 911 education for community members on the Sepsis Alliance, and these are direct hyperlinks, as well as the link to our toolkit at the top that take you to that, and that has all the resources you need to do community education. I did put an example SBAR for the urosepsis here so that you can take a look at figuring how you're going to report to the physician if you think that signs and symptoms are present for sepsis. I do have another resource that when I saw the school nurse on here, there's a website that I will send to you, Deb. I think you're probably aware of it. There's a whole K through 12 educational programs for kids to teach them about sepsis, and that's most often or they use cut, clean, and cover as an example for cut, clean, and cover sores on students, young people. When they've had a cut, be sure we clean it and take care of it and cover it. But that has a lot of great education specifically for K to 2, 3 to 4, different age ranges in there. Next slide, please. We have been celebrating Sepsis Awareness Month for several years. Our hospitals participate and have sepsis programming and education for their staff and their communities. And these are some pictures of them taking care of business around Sepsis Awareness Month. And I'm so grateful for the joy that, we can share here through our work. Next slide, please. We do have goals that we've developed for Indiana hospitals, and that is to try to improve our bundle compliance that I mentioned we get when they get in the ER, as well as bundle compliance for patients who develop sepsis as inpatients. But on the top right, are we doing oral hygiene to the best of efficacy? Are we hydrating our patients? Are we providing patient education materials for them? Note, I've given you several opportunities to use our sepsis education, as well as considering education about maternal sepsis in our OP departments, and focus on the quality improvement for hospital onset inpatient care and the associated pneumonia production that causes readmissions. So oral hygiene may prevent our readmissions for sepsis. Next slide. Long-term care and home health Think about early identification of sepsis using the risk factors and the known signs and symptoms. Prep that SBAR report to consult and teach people how to do that. And use your advanced practice providers to test the SBAR as well as implement it, and use that as a communication tool in order to be very prepared for what you might see with sepsis and what you want to tell your advanced care provider in order to consider a consult for the hospital transport or to home health to ER. Next slide, please. All right, that's all I have for you today. On to another sepsis webinar, but I appreciate the questions. And are there any more questions that you'd like to ask? We can do open mic here for about a minute. Welcome. Deborah Bars, I would usually have on top of my head what that website is, a very easy website, but if you email me at rhancock@ihconnect.org, I will reply with you. I tried to get it quickly when I saw you on the line, but it's just fun. It's a fun resource as well as all the other content in that you'll appreciate. All right, thank you so very much. Yes, Mitzi put my email on there, and I appreciate you all and your work out in the continuum of care that that we are all working so hard to cover, with sepsis as one opportunity that we have. Thanks a lot.
Thank you, Becky, or Dr. Hancock, for such an informative presentation full of such great resources. If anyone has any additional questions, please pop them into the chat, and we'll make sure that we get those to Dr. Hancock.
Thanks. And you will send
Thank you
out the
again.
slides. So you'll send the slides so they have the links as well, right?
Yes, absolutely. Thank
Okay,
you.
thank you so much. Have a great day.
You too. Okay, so great presentation. So at this time, we'll now transition to the next part of our presentation, which will be equally as informative, I know, as Dr. Sharice Shavupalanchi and Pam Pantonis will be discussing strategies to help prevent respiratory infections this winter, as well as providing a COVID and monkeypox update. So Dr. Vupalanchi, I'll turn it over to you.
Thank you, Tammy. So I am going to cover immunizations to prepare for the season. That will include, as Becky mentioned, like flu, pneumonia, and COVID vaccines. So to preventing sepsis, it goes along. Immunization in one part is one part of preventing sepsis. So next slide. So first we'll talk about the influenza vaccine. So everyone 6 months and older are supposed to get a flu shot. So this year we have the flu shot gets reformulated every year with the circulating variants that happened in southern hemisphere. That's how it is tweaked. The formula is tweaked every year. So it's going to be quadrivalent vaccine. All the flu vaccines for this season are going to have 2 influenza A viruses and 2 influenza B viruses to cover for what might be the actual strains that will cause flu this season. It was a significant load of flu compared to the prior years in the southern hemisphere. It might happen to us as well. So it's important to get flu vaccine, especially for those people who have immunocompromised condition, or elderly, or have other risk factors to develop serious complications that might include pneumonia as well. So those people especially should get influenza vaccine. Everyone 6 months and older are supposed to get it. Next slide. So dosing, usually it is 1 dose, but children 6 months to 8 years of age, if they have not received 2 or more doses in the past, they're supposed to get 2 doses, at least 4 weeks apart. So if they have not gotten it, it's now the right time to go get the first shot. So the second one can be gotten 4 weeks later. Ideally, everyone should be vaccinated by end of October. If most people are vaccinated, the flu cannot circulate as much, because if less people are infected, less people are going to be infectious. So if somebody needs to get 2 doses, first dose needs to happen ASAP. Otherwise, try and get it done by end of October. And previously we used to deal with only flu, but now we have added COVID. So it's all the more important to get that done. Next slide, please. So it's the dose, there are various options for people younger than 65 years of age. They can get any kind of flu vaccine that is authorized or approved for that age group. There is no preference between this or that. They can get whatever is available based on their own preference or what's available at their pharmacy. It doesn't matter. However, for people 65 and older, since they are less likely to mount as much response, there are high dose vaccines. There are 3 formulations available this year. There is a Fluzone high dose quadrivalent vaccine. There's Fluvac block quadrivalent recombinant vaccine and Fluad quadrivalent adjuvanted flu vaccine. If these high dose vaccines are not available and they won't have access to those, they can get other kinds of vaccines. But if they are available, the high dose or the adjuvant added vaccine is preferable for older adults. Next slide, please. And there are several formulations, as I said, and some of them are egg-based and some of them are not. So the standard flu shots, they're like, there are names listed. There are several of them. These are approved for children as young as 6 months. There is egg-based high-dose flu shot that's for people 65 and older. And then there is adjuvant added flu shot, that's a Fluad, again for 65 and older. And there is a live attenuated flu nasal spray vaccine. So this is live, it's not like the other ones. So this is for ages 2 and 49 years. Though it is prepared, based on the egg, people with egg allergies can still receive this. It's not recommended for pregnant people or immunocompromised, certain medical conditions are over age 50, because this is a live attenuated vaccine. Next slide. And there are egg-free formulations as well. 2 of them are like cell-based and recombinant. They're both quadrivalent and are appropriate for elderly adults. So the cell-based one is good for 6 months older, and recombinant one is good for 18 and older. The recombinant one has 3 times the antigen, so it produces a good enough response even for elderly. Next slide, please. So if somebody is on antiviral medication because they were exposed to flu and they're taking preventive, and they still can get the inactivated influenza vaccine at that time, but don't take the live attenuated vaccine, because if you're taking antiviral and you take the live virus, it's not going to be as effective and will need to be repeated. So if it is an inactivated, you can take the vaccine. And keep in mind, it takes a week or 2 before the vaccine is fully effective. So plan the timing accordingly. If you have taken flu shots before, usually it is, you're aware that usually it is well tolerated. The next 24 hours or so might feel a little bit of, sore ache, feverish, and those kind of things, but people do in general do very well after the flu shots. Next slide. So who should not get flu shot? It's not for children younger than 6 months, because it's not approved for that group. If somebody had a life-threatening allergic reaction to a flu vaccine, not a good idea to take. This might include like gelatin, antibiotic, and other ingredients that are in the flu shot. Some people with the allergic reaction to one kind of vaccine might be able to tolerate another kind, but you might want to talk to your provider before taking that vaccine. Next slide. And people that need to take other precautions or talk to their healthcare provider before taking the flu shot is if somebody is acutely ill, they have some other infection going on, in that case, you're not going to mount a good response to the vaccine. So it is better to delay until after you have recovered from an acute illness. If somebody has a history of Guillain-Barré syndrome, they should not get the flu vaccine. So then talk to your doctor about that. And if somebody has egg allergy, in that case, you have to choose egg-free vaccine. Next slide, please. And now we'll talk about the pneumonia vaccine. And keep in mind, people with the flu can have complication with the pneumonia afterwards, so that it can be a double whammy, and people can have coexistent other respiratory conditions as well, and not all of them have vaccines. So it's good to take the vaccines for which conditions, wherever it is available. So this is the standard schedule for babies birth to 15 months. Pneumococcal conjugate vaccine, that's a PCV13. The dosing is a 4-dose series. So basically between 2 months, 4 months, 6 months, and again, the last one between 12 and 15 months. If you have a child that has not received full series of the PCV13 series, then they need to get 1 dose if they are healthy between the ages of 2 and 59, like 2 years and 5 years age, and they're considered caught up. Next slide. Then I'm going to jump to age 65 and older, because everything else in between is a little more complicated. So for 65 and older, if they have not received any pneumococcal vaccine anytime in the past, they have 2 kinds of options. One is taking PCV20, that is the newest pneumococcal formulation. If they take that, they are done. No further vaccines. And there is the PCV 15, that can be taken instead of the PCV20, which is the newest. But if PCV15 is used instead of the 20, they'll need to get the standard PPSV23 at least a year later. That is the standard pneumovax that has been around for a long time, but they would have to be spaced at least 1 year apart. Next slide. If somebody, as I said, like pneumovax has been around for a long time, that is the PPSV23. If somebody has received that already, they can receive either a 15 or 20 PCV15 or PCV20 1 year after. However, if they have received the PCV13, we used to call it Prevnar 13, if they have received that in the past but have not received the pneumovax, then they can get PPSV23, that is a pneumovax, 1 year after the PCV13. If pneumovax is not available, they can get the newer PCV20 vaccine instead. Next slide. So the groups that I didn't cover, the ages in between with certain medical conditions, I have the conditions listed, and depending on the condition and depending on the age, the vaccination series and recommendations are quite different, and it gets very complicated. So I have provided the links. If you have an appropriate candidate with any of these conditions, you can go there and find out the exact methodology of what they need to get and when they need to get those shots. Next slide. So yeah, we'll move on to COVID, and I'll try to go through quickly, so I'll give enough time for Pam to cover monkeypox as well. So current dominant strain is BA5 followed by BA4. So those are the 2 circulating variants, and we have seen that these strains can cause reinfections, and the infections can happen in people who have received monovalent vaccine and received a booster as well, but they tend to be milder in those that are vaccinated. Next slide, please. So because of that reason, that they can get reinfection, or people who have received the vaccine also can get infection from BA4 and 5. FDA recommended the vaccine manufacturers, to make a formulation that includes the newer current circulating variants. So Moderna and Pfizer have reformulated their vaccines. The currently authorized bivalent boosters from about 2 weeks ago have half dose of original strain and half dose of the BA4 and BA5 antigen, so they retain the effectiveness of preventing hospitalization, severe illness, and deaths that we know from the previous formulation, and they have the newer formulation from the current circulating variant. So they're anticipated to protect against infections from happening. That is the purpose of these bivalent boosters. And Pfizer is authorized for 12 years and older, and Moderna is for 18 and older. Either of these boosters can be given as a single dose at least 2 months after the last dose. They cannot be used as a primary series. So people can get the bivalent booster at least 2 months after completing the primary series, or at least 2 months after their last booster dose. Since the bivalent has been available for these age groups, the previous version is no longer an option to take as a booster. So primary series is going to be just the previous formulation of monovalent, and bivalent is for the booster administration. If somebody received Moderna or Novavax for the primary series, they still can get this bivalent booster by Moderna and Pfizer. Novavax has requested for FDA approval, but that has not happened yet. As of now, the two bivalent available are Pfizer and Moderna. Next slide, please. So this shows that whether you get the primary series or primary series plus 1 booster or primary series plus 2 boosters, you can get the bivalent booster at least 2 months after the last dose. Next slide. No changes to pediatric age group for which the bivalent is not authorized. So this is for people who are not moderate to severely immunocompromised, 1 dose, 2 months after the previous dose. Next slide. Next slide, please. So this is for immunocompromised. So the main change is what is considered fully vaccinated additional primary dose in the immunocompromised. Still 1 dose bivalent for that group as well. So if somebody is acutely ill, they should not take it until they recovered from the acute illness. If somebody had a recent infection with COVID, they can wait for 3 months from symptom onset to take this vaccine. But take into account their all other risk factors to make that determination. Next slide. Next slide, please. So I'm going to skip this slide and that slide. This is important. Influenza vaccine and COVID vaccine can be given at the same time. Just give it in the different arms. So they can get protection for both conditions at the same time. If they choose to take at different times, that's okay, but it is completely fine to take both on the same day. Just give it different arms. If somebody has received a monovalent booster instead of the bivalent booster after it has been authorized, a single VAERS report needs to be submitted. So CDC is aware of what happened and then can watch. Next slide. I think I'm now turning it over to Pam.
Thank you so much, Dr. Vupalanchi, and good afternoon, everyone. I wanted to share just in a few minutes of monkeypox information with you. As of yesterday, we have actually the number went up a little bit. We have over 22,000 cases that have been reported nationwide, with 1 death being reported out of California now in the US. We also stand at 194 cases in Indiana. Just a reminder that monkeypox is spread by close personal contact, skin to skin, very close contact, can be sexually transmissible, but also some other ways as well. Close personal contact, respiratory droplet, again, within probably that 6-foot radius of respiratory droplets, and then items that have been contaminated with lesion fluid like bedding, clothing, or towels. Within 5 to 21 days of exposure, We've talked before about that prodrome flu-like symptoms can appear, but doesn't have to. Up to a half of cases have reported that that prodrome does not appear, and the first symptom actually can be the characteristic rash. We do continue to work with providers to get them access to TPOXX, oral antiviral treatment, and providers can access that through our teams here at the Department of Health. And then we also have Jynneos 2-dose vaccine available from Bavarian Nordic. It's a 2-dose subcutaneous injection given 4 weeks apart. And the good thing about Jynneos vaccine is that while it is a live vaccine, it is not replicating. So it can be given to individuals with weakened immune systems, immunocompromised, pregnant women, without any concern for ill effects. Next slide, please. So of our Indiana cases, most of those cases have occurred in the young adult to up to 50-year-old age groups, with about 95%, the vast majority being male, but not all of them. We do have a handful of female and a couple of pediatric cases, and from 21 or at least 21 different counties throughout the state. And while the majority of cases have occurred in men who have sex with men, not all of them have. So anyone, it's important to remember that anyone can get monkeypox and should be tested if they have a compatible rash, especially if they have been exposed. If we look at other demographic breakdown like race, about 34% of cases have reported being white, 38% have reported being black, and Black individuals account for about 9 to 11% or so of the population. So we are seeing some disparity, higher occurrence in Black population, particularly Black men. Important also to know now that cases are declining globally here in the US and statewide. And we'll take a look at the monkeypox dashboard here in a minute, but due to the aggressive vaccination efforts, education, and prevention that have been underway. So good news seeing those cases declining across the board. Next slide. So, whoops, next slide. Could we go to the next slide? Thank you so much. I won't go through all of this in the interest of time, but we do continue to provide access to Jynneos vaccine, TPOXX treatment, conduct community partner outreach and education, including updating talking points for our partners at 211 to answer those questions that may come in. Also have guidelines on our website for correctional facilities, vaccination palm cards in English and Spanish, and a wide variety of resources and materials. And we'll go to the next slide. This just shows you our monkeypox dashboard. A quick a screenshot from our dashboard at monkeypox.health.in.gov. And you can go to the link directly shown on your slide, showing total case counts, increases or decreases day to day. You can see from the epidemic curve graph there in the middle that cases are declining. And you can also, if you were to go to the site and scroll down, you'll see information on demographics for those individual cases, such as race, ethnicity, age group, and gender. And that is updated daily, Monday through Friday by 5 p.m. Next slide. We also have information. We've seen some false positives that we have reported here in Indiana and also across the country. And I call your attention to a recent Morbidity and Mortality Weekly Report article that CDC published, I believe it was last Friday. Just some information on false positives. When we get positives from patients that have atypical signs or symptoms or no apparent epidemiologic links or risk factors, recommendation is to retest, re-extract and retest those specimens And you can take a look at that link to that MMWR article. Next slide. Our laboratory has resumed monkeypox testing. We took that pause for a little bit to work through some of the issues that we had with some of the false positives, but our lab has been up and running since August 29th, and we do have that partnership also with other commercial laboratories throughout the country that most providers are used to using. So we can do testing through our state public health lab, but also a number of commercial reference laboratories also conduct monkeypox testing upon request. Next slide. And then some of the testing guidance, and you can take a look at this on our website. If you encounter a patient that may potentially have monkeypox, we have plenty of information up on our website in terms of what specimens to collect, how they need to be shipped, how they need to be stored, and what testing supplies and materials are needed to collect good specimens for testing. Next slide. We'll go ahead and skip through this. We do have some new case investigation forms available and training that our Epidemiology Resource Center put out last a couple weeks ago for those collection of specimens. Really want to call your attention to our website at monkeypox.health.in.gov. Lots of information for providers, local health departments, the public, and additional resources. It's kind of our one-stop shop for all things monkeypox, also with links to the CDC monkeypox website. Next slide. And then finally, we do here at the Department of Health continue to host monkeypox vaccination clinics for individuals at risk of exposure. We encourage our local health departments to host those clinics as well. We're now in process of offering those second dose clinics for that second dose of vaccine, and we'll be wrapping those up through the end of September. Next slide. And with that, I will turn the program back over to Tammy. I think we're getting really close to time, but we may have time for a couple of questions.
Yes, thank you so much, Dr. Bupalanchi, and to Ms. Pantones for your presentation. Michelle, in the interest of time, I think maybe we'll go ahead and scoot through the polling questions and allow kind of open it up in case anyone has any questions for Dr. Bupalanchi or Pam in the last couple of minutes that we have. Feel welcome to answer them direct or ask them directly, or if you would like to place them in chat. Okay, so we did answer a polling question there, I see. And the polling question was just about if you would like to hear more about clinical aspects of infections, such as presentation of those, complications associated with infections, or management of illness. And it looks like that folks are very interested in hearing more about those in future webinars. And Michelle, maybe how about we Mitzi, are you seeing any questions in the chat? Is anyone asking any questions in the chat?
I have not seen any questions.
Okay, so we do have one more polling question for you, and that's if you could just, we like to kind of gauge your satisfaction with our events, with one being dissatisfied, one being very satisfied. If you could just indicate your level of satisfaction, we'd appreciate it. And then Michelle, if you could go ahead and move us to the other slides once you're able to. Before we conclude the meeting, we wanted to just take a minute and invite you to engage in the various partnerships for community health or community coalitions that we have that we are supporting and facilitating across the state. If you're not already participating in one of these communities, please feel welcome to reach out. You're welcome to reach out to me at tgeltmaker@qsource.org, and I can connect you with the quality improvement advisor that is facilitating and supporting coalitions or partnerships in those regions. Next slide. We also want to invite you to some upcoming webinars that are happening next month, as well as our public health update in November and our one scheduled for January. Next slide. We also wanted to share a QR code with you. By scanning this code, this will take providers and community members to a landing page with more than 70 resources that QSource has that are available in English and Spanish. We also have more than 31 podcasts, as well as recordings of the events that we have done with Pam Pantonis and Dr. Vupalachi in our COVID-19 public health update series. Next slide. So on this slide, well, one, we want to thank all of you for joining us. We always appreciate your willingness to join us. We always appreciate Dr. Vupalachi and Ms. Pantonis, such informative information and updates that are so critical for the work that we are all doing. You also see at the bottom some additional ways. In addition to joining our webinar, you can also connect with us through Facebook, Twitter, LinkedIn, and Pinterest. So once again, thank you all for joining us today. We look forward to having you again join us for our October webinar with the Indiana Recovery Network and our next public health update on November 9th with Indiana Department of Health. Thank you, everyone, and we wish you a great afternoon.